Welcome, everyone. My name is William Bullman. I am the medical director for pulmonology at Veracyte, and we are very happy to welcome you all to this ATS webinar, integrating the Envisia Genomic Classifier to improve ILD diagnostic and prognostic confidence. Our speakers today are Dr. Fayez Kheir, the Director of Interventional Pulmonary Research at Mass General in Boston, and Beth Scholand, who is the Director of the Interstitial Lung Disease Program at the University of Utah. The key learning objectives for our webinar this evening: to discuss the importance of an accurate ILD diagnosis, to review the updated clinical guideline recommendations for diagnosis of IPF and PPF, and particularly in the latter, the new recognition of that disease phenotype. And then finally, to discuss how the Envisia Genomic Classifier can be integrated into the clinical workup for a patient with interstitial lung disease. With that, it is my pleasure to welcome Dr. Scholand.
Good afternoon, good evening. Happy to be here. And I'd like to move forward now and just review some of the new things we know about our guidelines. But before I do that, I wanted to just remind all of us, and most of us know this, but as we work in the interstitial lung disease world, it's important to be as accurate as we can for our diagnosis, not only to sort of set to the stage so we can kind of help the patient understand what they might be expecting, but it really informs our therapies. And these two graphics from studies that have been done over the years highlight, I think, some of the more important aspects of how therapy can alter disease. You see here on the left-hand side, a graph of using mycophenolate or CellCept in the setting of connective tissue disease-related interstitial lung disease. And when we use this medication in these connective tissue disease-related ILDs, we can see that we can slow the progression or even improve patients' lung function. But what's not shown here, and what we know from the NIH-sponsored clinical trial looking at immunosuppression in IPF, is that we actually can cause harm using these exact same medicines, immunosuppression, in the setting of IPF. So being more precise and clear on what we're looking at can help us decide whether medicine that we're thinking about is either going to be helpful or harmful. And here on the right-hand side, we know that with the use of antifibrotics, we can slow disease progression in IPF and in many of the progressive pulmonary fibrosis diseases. So, medications and their impact on disease depend very heavily on what we know about the diagnosis of their specific interstitial lung disease. And so the next slide here is really to review what's been updated. So I think most of us in the audience understand how we work up interstitial lung disease and how we think about IPF. And we've been working within this world, understanding how we work our way down an algorithm to get to a diagnosis of IPF. And in the guidelines that were just published last month, a few key changes deserve to be highlighted. The first of which is that although we've been talking about this for a while, it's officially now in the guidelines that the idea of having probable UIP on a high resolution CT scan, if we take that probable UIP reading, bringing it to a multidisciplinary discussion and understand the appropriate clinical setting, and say here a 60-year-old plus man, former smoker with no known other risk factors, we can make a confident diagnosis of IPF without pursuing a lung biopsy. Sometimes we think about a BAL to help augment our information, and this may be also something we would consider in the setting of a multidisciplinary discussion. But this is to say that the role of the probable UIP CT scan has taken a higher priority now. We can understand how that fits in the full spectrum of understanding interstitial lung disease and IPF diagnoses. The other key change here is that the transbronchial lung cryobiopsies have come a long way now, and we've seen over the years that since the last guidelines, the use of the cryobiopsy where that's helpful, and now the guidelines lead us to understand that we may be able to use that cryobiopsy instead of a surgical lung biopsy in centers who have the appropriate expertise. The other thing that came out of these guidelines is this idea of progressive pulmonary fibrosis and really refining our understanding of what is progressive pulmonary fibrosis. This is a new term. We've used other terms in the past for thinking about progressive interstitial lung diseases. And the guidelines have defined this for us so we can think about it in our clinical practice. And they've defined it as a person with an interstitial lung disease of known or unknown etiology that's not IPF, who have 2 of the 3 following criteria occurring in the last year. So a patient may have some worsening respiratory symptoms. They may show some physiological evidence of disease progression. And this is defined in these guidelines as being a change in the absolute decline in the FVC of greater or equal to 5%, or an absolute decline in the DLCO of greater than or equal to 10% within a year of following a patient. The third way we might define progression is by the CT scan. So radiologic evidence of disease progression, either by seeing more or worsening traction bronchiectasis, new ground glass around traction bronchiectasis, new fine reticulation, and increased extent or increased coarseness of the reticular abnormalities, new or worsening honeycombing, and increased lobar volume loss. So these give us some very clear guidance on how we think about progressive disease. I think this graphic is really helpful, and I love the visualization of how we think about interstitial lung diseases and the progression. Now, we all know that IPF progresses. We deal with that, and we worry about patients with IPF and the rate that they'll progress. But we sometimes forget that all the other interstitial lung diseases, almost all the others, are known to progress. And this graphic shows us that, within the distribution of idiopathic, autoimmune, exposure-related, et cetera, how we think about which of these diseases progress. And the areas that are more green, show more progression. So as you might imagine, some of the autoimmune diseases that, such as scleroderma, tend to progress more rapidly, say, than others. So this graphic helps us when we think about diagnosing a patient, who we can anticipate might have progressive pulmonary fibrosis. Now let's think about a case, and we'll be coming to and from cases throughout this webinar, but thinking about case 1 is a 70-year-old male. And this gentleman has had a chronic cough for more than 2 years, as is a common presentation. And he was admitted to the hospital with worsening shortness of breath, and a chest x-ray showed interstitial infiltrates. Workup was negative for autoimmune or hypersensitivity blood serologies. He has a history of GERD. He has a history of smoking, but quit 20 years ago. No family history of IPF, no burrs, no jacuzzi, no humidifiers. His pulmonary function test shows restriction with an FVC of 62%, an FEV1 of 71%, and a decreased DLCO at 64%. And his CT scan is shown here. So we need to think a little bit about this CT scan and what that pattern might be, as if we were in a multidisciplinary discussion. And in this case, you can see that this patient has a peripheral reticulation. You can see that he has traction bronchiectasis, but what is absent is honeycombing. So the next slide. So what is that pattern? You see the right distribution of disease, like a UIP pattern, but not honeycombing. So just to remind the audience, it seems like we have an audience that understands this very well, given the response to the poll. But a UIP pattern, the more UIP-like, the higher our diagnostic confidence that somebody has a diagnosis of IPF, or we can understand what's going on. So a patient that has a UIP pattern, we understand has subpleural and basilar predominant disease, and has honeycombing with or without traction bronchiectasis and a reticular pattern. Now, it moves a little bit away from being confident for UIP to a probable UIP pattern when we don't have honeycombing, but have the other features. An indeterminate for UIP pattern is highlighted here with subtle reticulation, maybe some ground glass opacity, some lung fibrosis, but not really clearly distributed in an obvious way. And then we have the alternate diagnosis, which is almost certainly not UIP when we see things like cysts or full-on ground glass, mosaic attenuation, nodules, completely different patterns, diffusely throughout the lung.
And Dr. Scholand, sorry to interrupt.
Please.
I think also just to add, probably only 2 images or 2 slides might not be enough to go over all the CAT scan. So although this could be a probable UIP, also indeterminate UIP could also be in the picture as well in this HRCT. It always depends on who is reading it. And there's sometimes disagreement between even radiologists when they read HRCTs. What do you think about that?
No, I think that's a great point. I mean, I think, you need the full spectrum of the CT scan to see how it moves, from apically to basally, where the fibrosis is, what indeterminate features might be present in one area that's not in another area. And you're right. I think one of the big points that you bring out that we all see in clinical practice is variability, and radiologists, confidence, and even confident radiologists, disagree a little bit on what they're seeing visually. So there's a lot to be looked at in a CT scan, and there's no perfect answer, is there? Yeah. And we just talked about this. So yeah, establishing a confident diagnosis may be challenging for a variety of reasons. I mean, we just using our clinical sense and our radiology, we can have difficulty getting to a solid diagnosis. Our clinical evaluation really depends quite a bit on the examiner and the patient, really. So how able is the physician who's taking the history and the patient able to have a communication that's going to make it clear what's gone on? What is that patient's history? Have we gotten a full, exposure history? Do we know how to ask the right questions to get autoimmune history out of the patient? Does a patient, that sort of thing. Time constraints. I mean, we're all busy. We have to, we have busy clinics. We got patients waiting. At some point, you have to move on. And our level of experience with ILD, and how we ask these questions. All of this can really change our perspective on what we think is going on with a patient who presents with an interstitial lung disease. As we just talked about, from the high resolution CT scan, the interpretation may be variable, the radiologist experience may be variable, and in the end, that adds up to maybe missing up to 60% of the cases of UIP that, by when we ultimately get to histopathology, we may miss as many of 60% of those by CT scan alone for a diagnosis of UIP. So the Envisia classifier is hopefully a complement to the work we do now, right? We have our clinical evaluation, we have our high-res CT, we have our multidisciplinary discussion, but this genomic classifier can really be that missing link in many cases where we get a little more information, very valuable information, can help us with our diagnostic confidence in moving forward with therapies. So as we move on over the years, just as we sort of talked about the cryobiopsy and how our experience with that over the years has taught us what a valuable tool that is, we might see that our future diagnostic algorithm will include this integration of the genomic tool, the genomic classifier, helping us with our multidisciplinary discussion, providing additional information to help us with our diagnostic confidence. And I will pass the baton.
Thank you very much, Dr. Scholand. So in the next few slides, we're going to discuss how can we do Envisia, what is some clinical evidence behind Envisia, and how can we incorporate Envisia in our clinical practice in interstitial lung disease. So Envisia is done with a bronchoscopy, either under moderate sedation, where 3 to 5 transbronchial biopsies are sampled, or under general anesthesia if you are combining it with a cryobiopsy, or if it's the preference of the institution or the operator to do it under general anesthesia. As we said, 3 biopsies are enough. Usually we can take them from the lower lung zones. If 5 is taken, we can take 2 more from the upper lung zones. We don't have to take any biopsies from the most diseased lung tissue on the CAT scan. Also, we only require minimal alveolar tissue from our sample in order to send for Envisia study. So once we do the 3 biopsies, we put them in tubes, and we had a box that is given by Veracite, The box will go to a Veracyte central lab, where all the biopsies are pooled and single-horde transcriptome library comprising 190 genes that are found to be predictive of UIP versus non-UIP pattern will be generated and sequenced. In up to 2 weeks, you will have the results back. It's either positive for molecular UIP pattern or negative for molecular UIP pattern. So it's important to remember also that UIP is a pathological diagnosis. Although IPF comprises, UIP is associated with IPF. However, UIP can be present in many other non-IPF diagnoses. Fibrotic HP or connective tissue disease, ILD, can have a UIP pattern. Regardless of the clinical diagnosis we know that unfortunately UIP is associated with a poor prognosis. And in the graph on the right side, you can see that patients who have a connective tissue disease or IPF UIP pattern will perform worse as compared to patients, for example, who had a connective tissue disease. And in the era of antifibrotic and immunosuppressant, as Dr. Scholand alluded to before, we know that, at one end, immunosuppressants is beneficial in patients who have inflammatory component in their ILD, but they can cause harm if were given to patients with IPF. On the other end, antifibrotics also have some their adverse or side effects. Even in the clinical trials, up to 20% of patients had some adverse events from antifibrotics. Precision medicine becomes very important. This is a recent study that showed that a lung biopsy was important in changing a treatment strategy for patients for ILD. Up to a third of patients, when a lung biopsy was added to the MDD, it led to reclassifications of the cases or an increase in the diagnostic confidence. That results in a significant change in treatment strategy. So the MDT team were less inclined to wait and see, or less inclined to prescribe steroids, and were more confident to treat with antifibrotics or immunosuppressive drugs. Also, it's important, the graph at the bottom is very important to show that if, initially some patients were labeled with IPF. However, after the lung biopsy, they were labeled with non-IPF. And these performed much better than patients who were labeled as non-IPF and eventually were labeled as IPF. As you can see, the gray one, where patients were IPF and then eventually were non-IPF after their biopsy, performed much better than in the red line, where they were non-IPF and eventually were labeled as IPF. And that tells you a UIP pattern is very important and will inform your treatment strategy in such patients. So how can we incorporate Envisia in our practice? As we discussed before with Dr. Scholand, usually Envisia is important when you have an HRCT pattern, which is indeterminate for UIP. Or if you have a probable UIP pattern, but the clinical factors does not fit IPF very well. For example, a woman less than 60 coming with a HRCT pattern of probable UIP, Envisia can really help diagnose a molecular UIP pattern versus a non-UIP. So the Envisia was clinically developed and validated from the BRAVE trial, which is a large prospective multicenter trial. These enrolled patients who are undergoing clinical evaluation for interstitial lung disease. The majority of patients had surgical lung biopsy, less commonly cryobiopsy or transbronchial biopsy. However, all the pathology samples were reviewed by a central expert pathologists, and CAT scans were reviewed by a central radiologist. Also, patients underwent a centralized MDD to determine if they have a diagnosis of IPF versus non-IPF. Only patients with confirmed histopathological label was used in the training as well as validation of the Envisia Genomic Classifier. And as you can see on the right side of the screen, there were a diverse set of ILD patients represented. Up to 55% had a UIP pattern and 45% has a non-UIP pattern. The most common UIP diagnoses were IPF, fibrotic HP, and connective tissue disease, whereas the most common non-UIP was NSIP, HP, sarcoidosis, and RB. The two independent prospective clinical validation trials was able to show us that Envisia classifier identified a molecular UIP pattern with a specificity of 91% and a sensitivity of 63%. So this is a study where a combined Envisia classifier and radiology was compared to radiology as alone, to assess the performance, whether if we add Envisia to radiology, will that improve our diagnostic accuracy or not? That was against a reference pathology of UIP. And that study showed if we combine Envisia with radiology, our sensitivity to detect a UIP pattern increases from 34% up to almost 80%. Without affecting the specificity. So for the purpose of the recent published guidelines, a systematic review regarding the Envisia classifier was done with all the available studies in the literature. And the 4 relevant studies were identified from the literature. And the meta-analysis showed that the pool sensitivity for Envisia to detect UIP was 68%, with a pooled specificity of 92%. And in the same study, it showed that in the clinical trials where agreement between categorical IPF and non-IPF diagnosis was established, there was a high agreement, up to 86 and 88%. It also showed that the confidence in obtaining IPF diagnosis in the clinical studies increased from around 40 to 50% up to 90 and 93% in the clinical trial, showing a higher confidence in IPF diagnosis when Envisia was used. Now we will go back to Dr. Scholand.
Thank you. So let's talk a little bit about another recent study that I think is really interesting as it kind of replicates what we do in our clinical practice and where we might think about the genomic classifier in clinical practice might fit in. So this was a study where we took, where 103 board certified pulmonologists took a survey. They saw 5 cases that were randomly selected from 11 cases from the BRAVE study. These were cases that were patients that had undiagnosed interstitial lung diseases, where we had the Envisia result as a UIP positive, and that had undergone a central multidisciplinary discussion that resulted in a final IPF. Diagnosis. So it was a prospective randomized decision impact study that looked to see what that impact of having the classifier in the physician's hands would do to the clinical decision making. So these were the results. And the bottom line, or the top line, is the number of and confidence of IPF diagnoses increased by having the genomic classifier for use. So you'll see on the left-hand side that the IPF diagnosis, when a patient had, or when the physician had the genomic classifier, it went from 30 to 69% and markedly reduced the number of unclassifiables. So a physician having the genomic classifier for use could ultimately diagnose a patient with IPF and move forward with therapy. Similarly, the confidence in that diagnosis increased remarkably when you had the genomic classifier for use. So initially, in the initial 103 physicians who underwent the 5 case, they had about a 6% confidence in their diagnosis, but having the genomic classifier changed that by 7 times, up to 42%. So I think this shows you that having more data and having data that's reliable, that Dr. Kheir walked us through to show us how the 91% specificity really helps us to make that diagnosis with more confidence.
All right. Well, thank you, Dr. Kheir, Dr. Kheir, and Dr. Scholand. We are going to move on to some real-world cases. So we're going to return to case one, our 70-year-old male. This is a gentleman with chronic cough for 2 years, former smoker, history of GERD, HP panel and autoimmune panel were unremarkable, and no exposures or family history. And he had reduced FVC, reduced FEV1, reduced relatively in proportion, and a normal ratio with a remarkably reduced DLCO. And we had a CT that was indeterminate for UIP.
I think we can discuss.
I think in a situation like this where you have, features leaning towards an idiopathic etiology, but you have a non-diagnostic CT scan, you certainly want more information. A cryobiopsy, as we highlighted while you can do a cryobiopsy and get the Envisia classifier with it, and a lot of people do that. And I think that I'd love to hear what Dr. Kheir thinks about that. You really don't necessarily need to go in that direction. And the transbronchial biopsy will get, is a slightly less risky procedure. And what we're really looking for is the genomic signature of UIP. And so that's the information we wanted. I don't think I would pick just doing a BAL alone in this setting, although it's certainly, and that would be choice A, although that certainly would be supported by the guidelines. But in this case, I think we still are wondering if UIP is present, so it's nice to get the genomic classification as well.
So again, as Dr. Scholand is saying, this is a 70-year-old. He's a male. He was a smoker, and he has a workup which is negative for autoimmune or HP panel. The CAT scan, if you recall the first poll, people answered it was probable for UIP. And we discussed both together, Dr. Scholand and myself, that it could be either probable or indeterminate. It depends on how radiologists, how we are reading it. So in this case, if you want to obtain an increased confidence in your diagnosis, I agree with Dr. Scholand. Probably I will only offer this patient Envisia to increase the confidence in the diagnosis of IPF. I wouldn't offer this patient a cryobiopsy because I don't think it's going to add anything to the patient, and it might put him on a higher risk than benefit, especially with his low DLCO, especially that we are entertaining likely the idea of IPF and not other diagnoses.
I agree. And we were preaching that DLCO of 34%. We know we're in that higher risk group for both the cryo and certainly for a VAT. So this is where the transbronchial and the genomic classifier really shine, where we have risk, but we need more information. I think this is a great case that illustrates the benefit.
Yes.
Dr. Kheir, do you have criteria for those patients whom you consider cryo safe or unsafe? Do you take it case by case?
No, first and foremost, if we are gonna offer a cryobiopsy, it should be done under the context of an MDD, where I have an ILD specialist where we discuss the case and see whether this patient will benefit from cryobiopsy or not. Second, as we discussed, we're going to look at the PFTs. In a patient with DLCO of 34, which is less than 45 or 40%, these patients might be at a higher risk of complications from the procedure. Also, we look at whether these patients have pulmonary hypertension or not, whether they are on high oxygen level or not, because these cases are usually done under general anesthesia with a rigid bronchoscopy. So we need patients to tolerate the procedure safely in order to do the procedure. But that does reflect what most of us face in the clinical practice.
I agree. That's why Dr. Kheir was so smart to point out the fact that we really didn't have the full scan spectrum, and that we could go either way based on what we were able to see.
Wonderful. All right, if you want to move to the next slide then. They went into this procedure with a clinical differential diagnosis of HP, NSIP, and IPF, and the recommended next step was a BAL to get information about whether they had a lymphocytic lavage, and then transbronchial biopsy for purposes of getting the Envisia Genomic Classifier. This patient had prior test results with negative serologies and a negative HP panel, and their Envisia classifier was positive for UIP. And again, remember that's a designation with very high specificity and 91% positive predictive value for UIP in that face of that positive result. This patient was then, in the context of this information, presented at their multidisciplinary discussion and taking the serology together with the BAL results, which are shown on the right. Relatively unremarkable BAL, other than just outside the normal range of lymphocytes, but within the normal range of what you would see for IPF. And the rest of it was unremarkable, except for a slight elevation in eosinophilia, certainly nowhere near the 25% you'd see within an eosinophilic lung process, but in the range where you can see eosinophils in patients with IPF. And so their treatment recommendation was antifibrotics. Dr. Scholand, would you agree with that?
Absolutely. And I think, the diagnostic confidence study that I presented in the real world demonstrates that the more confident you get, the sooner and more comfortable you are using antifibrotics. So I think that's the right thing to do.
That brings us to our second case. The second case is a 77-year-old man. He has been short of breath for 5 years. That shortness of breath has been worsening in the last month. He has a past medical history of coronary artery disease and atrial fibrillation. He does not have any cough and has no significant exposures that he reports. He's had no symptoms of rheumatologic disease, no symptoms of GERD. He is a former smoker with a distant quit date. And he has an occupational exposure that might or might not be significant. He's worked in a steel mill for 10 years. So probably exposed at some point to potentially to things like asbestos that might be found in a steel mill. There's no family history, and on lung exam, he has bibasilar crackles that are a little asymmetrical and no disease clubbing. These are his pulmonary function testing results. He has a FVC that's 78% predicted, an FEV1 that's reduced slightly out of proportion to that, but an FEV1 to FVC ratio that's pretty close to normal. And again, a rather reduced DLCO at 42% predicted. He had collagen vascular disease serologies that were all negative, and he had an HP panel that was excessively positive. What do you make of that, Dr. Scholand?
I make that this patient has definitely been exposed to quite a bit of mold, and I'm curious about where that might have come from. House, activities, outdoor activities, etc. The positive panel means exposure. It does make us suspicious about the possibility of hypersensitivity, but as we know from the hypersensitivity guidelines, it's not a diagnostic finding. It just means there's been exposure sometime in the past. So we definitely would have to correlate that with known exposure, finding it in the environment, and also with the right histopathology.
How much weight do you put on that exposure of 10 years of working in a steel mill?
Well, I think working in a steel mill, you could think about fluid workers, sort of lung, but I think in typical a steel mill, I wouldn't be thinking was the mold source. I put that weight as being a potential problem and a potential etiology for the hypersensitivity, but I'm not sure I could correlate the mold with the steel mill. It's possible for sure. I mean, these environments are full of different things, but I don't know that it's not as clear as if you told me that his HVAC system, was growing mold in it and it was all over his house. Then I would definitely make that a positive correlation.
Of the patients that you ultimately diagnosed with HP, how many of them in general, just off the top of your head, have something that's positive on an HP panel that you can correlate?
Well, I'll say that I get it less and less, again, because the guidelines tell us that it's not a useful test. On the other hand, I do use it. The hypersensitivity panel, I tend to use it in the other direction. When I have hypersensitivity as a diagnosis, then the panel sometimes helps me look to find where that source might be. So for example, again, this patient, if I already had histopathology that told me it's hypersensitivity, I get the HP panel, I'd say, you got mold somewhere, and that might drive them to go look at their HVAC system or something like that. That's maybe a better utility. I think people all use them differently. So that's a long answer. The short answer is I do not know the percentage. A lot of people will have positive exposure at some point in their life to these common molds.
Sometimes patients won't remember even that they had an exposure until you have the HV panel.
No,
that's true.
Absolutely true. And it is, at the very least, a basis for patients who ultimately get diagnosed with HP to go back and look at their environment and say, oh, is there some place in my environment where there's moisture in my home or in my workplace where I'm being exposed to these molds? And we have this patient's very interesting HRCT. I will let our panelists comment on what they see here. Dr. Kheir?
Yeah, I think there is some mosaic attenuation here. And when you have probably some mild ground glass opacity as well, I don't appreciate any honeycombing. I can see very minimal traction bronchiectasis. Again, it's only 4 slides, but that's what I can illustrate from these slides, and some minimal reticulation at the bases of the lungs as well.
There's some, we don't have more data on this patient, but there does seem to be some left chest wall abnormality and maybe some fluid around the base of the left lung. Dr. Scholand, any comments?
Agree. I don't think I can make a diagnosis from this CT scan alone.
Okay. And if you had to categorize it for
indeterminate.
Okay. Dr. Kheir, do you agree?
Yes, absolutely. Yeah. So again, I think there's no correct and wrong answer here, and I want to hear Dr. Scholand as well perspective for that. But it all depends, again, as we discussed, on the availability of cryobiopsy, also about the MDD and how they view the scan, and how do we decide about which modality to pick. At least in my opinion, if we were evaluating such patient, this patient has a CAT scan which is indeterminate for UIP, number 1. Number 2, this patient has in his history something that tells you it might not be IPF. But however, UIP pattern could be present with, for example, fibrotic NSIP or fibrotic HP. So I would have chosen a cryobiopsy with Envisia in this case, since I'm gonna do a cryobiopsy, if patient agreed on a cryobiopsy rather than a cryobiopsy alone. But again, I don't think there's a correct and wrong answer here.
The answer that was chosen for this patient was B, forceps biopsy with Envisia along with the BAL. Dr. Scholand, did you want to comment on what you would do in this patient?
Yeah, I think it's a great, we've been talking about this, and it's a great case to illustrate the fact that there's, heterogeneity in what we have available. In my case, I wouldn't have that option for a cryobiopsy with or without Envisia. So our debate at our MDD would be, should I do the transbronchial biopsy with the Envisia to try to rule in UIP and save the patient from a VATS biopsy? Or am I, this is so far in my mind from looking like IPF because it's such an indeterminate CT scan, I might as well just go to the VATS and get all the information in one swoop, right? And I think, you talk to 50 ILD doctors, we would have a different approach to how we would do this, as we're seeing right here. So I think I often will, in this situation, will have a conversation with the patient and just tell them that, we may get a nice answer off just doing a transbronch and the genomic classifier, but we may not. And are you okay with that? And if we get the wrong, if we don't get the wrong answer, not the wrong answer, if we don't get a definitive answer, what would you like to do? Would you be okay with the uncertainty, or would you want to pursue that VATS biopsy afterwards? So I think teeing it up and just sort of understanding what might come, what your results might be, can help sort of frame your next steps.
This person had a relatively unremarkable BAL, and their Envisia classifier was negative for usual interstitial pneumonia, negative for UIP. So in this instance, Dr. Scholand, you would move on to a surgical lung biopsy if the patient was amenable to it in the context of this negative Envisia result?
I think I would. I think I'd like to have some diagnostic certainty to move forward with my therapies. Yeah,
it's the test was designed for specificity. It was developed to optimize specificity. So the sensitivity of 60 3% actually means that there will be patients with UIP who get a negative result. And the general recommendation is they at least be considered for a continued workup. And that workup in many instances is pathologic sampling, either cryobiopsy or surgical lung biopsy. So what is your leading diagnosis for this patient? Does this person have connective tissue disease? Does this person have non-specific interstitial pneumonia, NSIP, IPF, or HP? This cryobiopsy in this instance showed cellular chronic interstitial pneumonia consistent with HP. So they saw interstitial lymphocytes, poorly formed granulomas, and that was a pathologic diagnosis consistent with hypersensitivity pneumonitis. And also consistent with their HP panel. It's a 60-year-old woman who was deemed by a multidisciplinary discussion to have an unclassifiable ILD. That is her CAT scan in the coronal and axial images. To the right, she has some very dense fibrosis that has sort of a peripheral predominance, but it certainly has an upper lobe predominance with some traction bronchiectasis. It is not a pattern that is exclusively peripheral or basilar that you would expect in IPF. So she was graded as unclassifiable, judged to be unclassifiable, and at 6 months, she's had a further decline in her FVC that exceeds 10%. She was brought back to the multidisciplinary discussion for review. Her FVC has declined from 45% predicted to 34% predicted. Her ratio is now supernormal at 112% predicted, and her DLCO has declined from 55 to 39%. And there is no polling question here, but would you consider this progressive pulmonary fibrosing ILD? Dr. Scholand?
Yes, she meets the criteria. She has, well, we don't have a worsening CT scan. But I guess technically speaking, we have to know that she either has a worsening CT scan or more shortness of breath, but she certainly has progression of her pulmonary function testing. And I would assume if we asked her, she's more short of breath than she was a year ago. So I would say yes.
Dr. Kheir?
Yes, I agree. The only question I also had, she was deemed unclassifiable ILD. So I was wondering, how did they do that? Through a biopsy, through MDD? We don't know the more information about that as well.
That is correct. And we don't have any information as to exposures and so forth. We do know that she was put on immunosuppressive therapy. In that context, and in the context of this new diagnosis, what would you do as your next step? Dr. Scholand?
Well, she has progressive pulmonary fibrosis, and I would use an antifibrotic that's approved for this indication for progressive pulmonary fibrosis. So I would initiate that in this patient. With a DLCO of 39%, and if you see a 34%, I wouldn't think that would be the time to pursue a biopsy. We could consider trying to be more specific in our diagnosis, but I think we know she has a progressive pulmonary fibrosis at this point, and I think initiating antifibrotics would be the right next move.
Okay. Dr. Kheir, any comments on either her horrific CAT scan or her decline?
Right. So she was on immunosuppressants, and she did not do well with immunosuppressants. So I think the best next step is to put an antifibrotics. If that patient, we had it initially, and the patient was not on either immunosuppressants or on antifibrotics, in that case, probably Envisia or a UIP pattern might be helpful to inform our next step in the treatment of such patient. But as Dr. Scholand said, patient was on immunosuppressant, did not get benefit. Patient is declining. Now it's time to put patients on immunosuppressants. Sorry, yeah.
Yeah, I think the debate is whether you stop the immunosuppression, but I probably would. but that's.
It certainly doesn't appear to have helped much. So
right, and as we talked about at the beginning of this discussion, we don't know what her diagnosis is. We're calling it unclassifiable. If we had more information ahead of time, we might have understood this was UIP or even IPF. And then we would know that immunosuppression was the wrong thing to do. But instead, we sort of did empiric therapy, and it doesn't appear to be working. And we know that this empiric therapy can actually cause harm. So in my opinion, I'd stop the immunosuppression and start the antifibrotic.
Agree.
So sort of summarize what we've been talking about, who do we think about? Who are appropriate patients for the Envisia Genomic Classifier? So when we think about clinical factors, patients that we don't have a known etiology, so we don't have a known medication, a known autoimmune disease, known occupational risk, but who has ILD, and we're left not knowing what's going on. High resolution CT scan factors that make us think about using the genomic classifier include probable UIP in patients that don't have those classic IPF risk factors, males over 60, former smokers, sort of things, or indeterminate CT scans. And an alternative diagnosis of UIP is helpful for the prognosis. So understanding if we have UIP in an alternative diagnosis could help us understand what to do next. And then in patients that finally we want to think about safety always. So in patients that are able to tolerate this relatively non-invasive procedure, but still is a procedure. So people who would be a candidate for standard transbronchial biopsy procedures with 3 to 5 samples. And so in this group of patients, this is a covered indication, and patients meeting this criteria would certainly be excellent candidates for the genomic classifier.
So in our final concluding question, I think we'll end. A participant has said, for patients like you described who meet the criteria for PPF, who are too sick to undergo procedures, what is a good empiric therapy regimen? And I guess that would be which of the 2 antifibrotics are recommended in this PPF if one is favored over the other.
Yeah, so the guidelines are pretty clear on that. OFEV has an indication, has the INBUILD trial that showed us that it's effective in progressive pulmonary fibrosis. Pirfenidone, while there's data that is suggestive of efficacy, it hasn't reached that threshold of definitively shown to be effective. So OFEV is probably the favored antifibrotic in the setting of PPF. So with that, we've reached the end of our webinar. I am very grateful to both Dr. Scholand and Dr. Kheir for joining us tonight and for sharing their perspectives, and very grateful to all the people who've participated.